afternoon. On behalf of Ashland County Family and Children First Council, I'd like to welcome you. The Family and Children First Council is a network of over 30 local agencies, social service entities, government officials, advocates, funders, and parents who work closely together. Our purpose is to increase access, capacity, and effectiveness of service supports for our children and families of Ashland County. By teaming together, we serve the most vulnerable children and their families by working to improve knowledge and understanding of services across health, mental health, various social service entities, education, developmental disabilities, juvenile justice, youth programs, early education care, and all for children prenatal through 21, sometimes a little bit older. We also serve to and work together to identify service gaps and to improve service delivery. Information about the council and the breadth of our services and programs are in the back for your convenience to take with you today. And today is a very, very special day. We're very, very proud to share with the community a special project under the umbrella of FCFC that was rather ambitious for our county, really. And it really represents an excellent example of how our county council works. We used a small amount of funds and local expertise with Dr. Lamont with AU and the collaborative planning skills of most of our executives of the council, plus some key partners, to produce a picture in time of Ashland County residents across various topics related to their health and wellness. We are very proud to share these results, and from the beginning, over a year ago when this project started, we did have full intent to share it well beyond the council bounds. And so we are proud to share the results with you, and please know that we've got hard copies for you all, and it's on our website, and the website information is at the back. And we want you and encourage you to use it for good purposes that you have, and it's to be offered to the county entities. It's good for strategic planning, definitely that's what the council is going to use the data for, and for shared decision making, informed decision making, and for various planning and fundraising activities. Of course, the sponsorship under the umbrella of FCFC, a very, very key co-partner of our project was the Ashland County City Health Department, Jelaine Dray as our health commissioner. And we were very, very fortunate to have grant funding provided by Ohio Department of Health, Child and Family Services. And a key partner is our Wayne County Mental Health and Recovery Board as an outside entity. And I wanted to show you the hardworking people who shepherded this whole project. As I mentioned, for over a year we've been meeting. Our chair is Jim Huntington, superintendent of the Board of DD. And we have a 14-member committee, and most of the major agencies you will take note of. We've got the health department, we've got the mental health and recovery board, we've got Jobs and Family Services, Catholic Charities, United Way, Parenting Plus, Access, Tri-County Education Service Center, and Help Me Grow, and of course myself as the staff of the council. And as we go forth, we know that we're going to engage lots more of the outer council members and the community in general is going to be very, very welcome at our table to address these issues. Some other thanks really quick for today. We are very, very fortunate, and we do thank Samaritan Hospital for this wonderful venue. And Danny, thank you for this nice room and comfortable room. Ray Herbst at the Health Department is videotaping us, so it'll be up on YouTube. And we had the wonderful skills of Melissa Martin at the Ashland Chamber of Commerce, who provided, actually she reformatted and really spiffed up the report for us, and that's back on the table. And then last but not least, we do want to acknowledge the wonderful citizens of our county for all of the people, the many people who completed our survey, and the people who sat with us, and very candidly offered their ideas in specific focus groups. So I'm going to hand this over now to Jelaine Dre, and to Joy.
Good afternoon, everyone. Thank you very much. It's a privilege for me to represent the Health Department. It's been an awesome privilege, actually, to come together working with FCFC, the Planning Committee, Karen Potter, working with the Woody H. Grant, Dr. Vermont, just everyone. It's been a real opportunity. And I have been asked to share with you today, Diane has given you a great snapshot of the community health assessment, but on my piece, with the health department, why community health assessment is important, and better yet, what we will do with this information that we have will be revealed today, and that we have learned from the assessment, and what's that all about? What does it mean for the future? So I will just kind of briefly share. Community health assessments are certainly nothing new. It's not a new concept. It's not a new concept, certainly for hospitals or health departments. We are required to complete a community health assessment every few years, and so the community health assessment from the health department's perspective was completed a few years ago, and so we were right in line to be needing to do another community health assessment, obviously. So through partnerships, it was a wonderful opportunity to see us come together and to complete an Ashland County-wide community health assessment. And our boards will be adopting this community health assessment as our health department community assessment, because we were involved in that whole process, the health department was. And most importantly is health departments, we cover infants through 110 years of age. We're very much concerned about every resident. And Family Children First Council obviously is very concerned about children and parents and young adults, and we are as well. So as part of our community health assessment piece and feeling comfortable to accept this, embrace this as our health department community health assessment, we were involved in the process of bringing adults in. Our adults had opportunities to complete the survey. We had some focus groups, and Dr. Vermont will obviously be sharing that information shortly here. But we were able to pull in some focus groups that focused on families, children with disabilities. We had a couple different various focus groups. So it is very much in alignment with what we are needing to do for the health department. And therefore, it also is aligning with accreditation. Again, that's a term that is not new to many. If you're in the hospital world, that is not a term, again, that's not recognized. So accreditation in hospitals has been around for a long time. Very familiar with that, although accreditation is very new to the world of public health. And so we as health departments are to be lining up to apply for accreditation and to be accredited within the upcoming years here. So again, it's lining up with our need at the health department to focus on accreditation 3 prerequisites for any health district around the state of Ohio is number 1, to have completed a community health assessment. Number 2, a prerequisite is to have a community improvement plan. And then the third piece is to have a health department strategic plan. So we are definitely moving along with this process. It's very encouraging. I couldn't be more pleased. It's exciting to work with county partners coming together, focusing on the needs of Ashland County, and now what we can do to try to make an improvement in that area. And then the health department will be kind of spinning off. We are required again to do our own strategic plan. But again, those will be prerequisites. Once those prerequisites are ready with other documentation for health department in preparation for the accreditation process. So just kind of wanted to tie in a little bit, obviously why it's a great thing, encouraging from the health department perspective, and just couldn't be more excited to work with everyone. We have so many great agencies in Ashland County. I just am so turning cartwheels inside because it's such a privilege working with so many entities that are in Ashland County and coming together and working collaboratively for the cause of Ashland County residents.
Hello, good afternoon. I'm Karen Potter, and I am the Grant Project Director for Child and Family Health Services. And I have that role in Wayne, Holmes, and Ashland County now, and I am very grateful for that opportunity. Diane did a great job kind of going through the funding source. I did want to acknowledge Bree Haviland from the Ohio Department of Health, who is our Child and Family Health Service Project Consultant, is here with us today, and I appreciate her making the drive from Columbus. And it's been a wonderful process to get to know one another and to get to know the Ashland community and how everyone works together. And I recently said at a Family and Children's First Council member, I think I forgot to tell them that this is a 5-year grant because we accomplished so much here in 1 year, but Ashland was just really ready to go, ready to get everybody involved. All the key players are already at the table, and that again has been exciting for me to watch. As you're going to see as we go through, Dr. Vermont is our community health assessment consultant for the grant, also a professor at Ashland University, and we very much appreciate his expertise. He has been our consultant at Wayne County for some years now, and so it's been nice to also cross-share what each county is doing to get new ideas. The community health assessment process is, well, we're going to go through each part. I'll let Dr. Vermont do that, but we first collected some secondary data, which Dr. Vermont will explain. And then we also did 6 focus groups, 3 that the Family and Children's First Council conducted, and 3 that the Health Department conducted. And then from there, we had the Community Health and Wellness Survey. And I'm thankful that we all worked as a group and we came up with the name, Help Ashland Help You. And we have a wonderful response, and Dr. Vermont will also go through the research and the results that we came up with for that. After he goes through all that, I will get back up and very briefly explain the next steps of what we will do with all that data. To me, data tells a story, and it's a small piece of what is really going on, because we want to help change the lives of Ashland County residents. We don't just want to collect data for data's sake. It really needs to take meaning and to ask more questions, and that's why we did the focus groups, so that we can learn more from the county residents' perspective and their own personal experiences, what's affecting them, what are the main concerns that they're dealing with in their lives, and how can we as a county come together to help make their lives better and make our lives better, whoever is living in Ashland County. So I will now ask Dr. Vermont to come up.
Thank you, Carrie.
Can you hear me well tonight? I have nervous energy. I like to walk around and have a clicker in one hand. So I think I'm going to go ahead and turn this off for now. If anyone has trouble hearing, let me know. I'll turn this back on. I'm not sure how you turn it off, but we'll give it a turn. I'm going to get right to the data. But before I do, in terms of how to utilize data, good data is going to produce more questions than questions that it's actually going to answer. One of the favorite questions is why? Why are we seeing this? And as a data gatherer, at least at this point, I'm going to just provide to you the information. And then the why comes a little bit later, because that's when you start doing some hypothesis, some research questions and so forth, so that you can then develop, at least initially, some type of ideas about how best then to interject the community into resolving some of these problems. As Karen mentioned, we had 3 different ways of collecting data. One was from secondary data. Second was from a needs, health needs survey and focus groups. I'm going to start with the secondary data, which is based on 5 areas: economics, health status, education, risky behaviors, and then child abuse and neglect. A lot of the secondary data you may already be aware of. Others of this may be a surprise to you. Unemployment. Since 2009, it has gone down, and actually has gone down rather significantly. Whether or not you utilize the official unemployment report or some of the other ways of measuring unemployment, the trend is the same. It has gone down not only in Ashland, but also Ohio altogether. However, median household income during that same time period has been rather stagnant. If you look at between 2008 and 2013, the median income is nearly identical. So basically, we're kind of treading water. We're not any worse off, but we're also not getting any better in terms of median income. So despite the fact that unemployment has gone down, median income is still stagnant. Children living in poverty has decreased ever so slightly since 2009. But not the levels one would have expected looking at the unemployment rate. So by combining these 2 variables together, the blue line represents unemployment that I've already shown you. The red line represents poverty rates among children in Ashland County. So if you look at 2013, 1 out of every 5 children lives in a household that is statistically in poverty. Back in 2004, 2005, we were around 12, 13, 14%. Look at the unemployment rate at this period of time, and this unemployment rate in 2013, 2014. If we were going to look at unemployment as being a good predictor for poverty, I would predict that childhood poverty in 2013 and 2014 would probably be somewhere around 12 to 13%. But it's not. It is still at around 20%. Which then goes into the idea then that median income is still stagnant. So in other words, unemployment and how much we have in this county, or how little of it we have, is becoming less and less of a predictor as it pertains to poverty rates, at least poverty rates among children. For single-parent families, that's the type of household that's going to be far more likely to be in poverty compared to other households. Okay. This was kind of a surprise to me, at least at the levels. But in Ashland County, households that are female only, that has children in it, almost 50% are in poverty. Compared to families that have children and have a married couple, it's well under 10%. Now, cash assistance programs. Those are, you basically were probably referring to temporary subsistence need families, are the welfare programs that we mostly look at in terms of addressing needs for people who are in poverty and have children in their household. One would expect that the TANF enrollments would be quite high, because if 1 out of 5 children are in poverty, would that not indicate that TANF enrollment would be quite high? Well, not really. Actually, enrollments in TANF, in cash assistance public welfare programs, is actually quite low, much lower than we find in Ohio. So in 2014, 3 out of every 1,000 individuals were participating in that public cash assistance program. However, when you look at food assistance programs, like SNAP, that more readily reflects the poverty rate in Ashland County and in Ohio. So in 2014 in Ashland County, over 10% of individuals were receiving some type of food assistance program through the SNAP program. Just in terms of looking at percentages-wise, in Ashland County, 2.6% were receiving tax public assistance, about 3.8% were receiving food stamps. So that's kind of economics, very briefly stated. Now we're going to go into health. First secondary data that we were looking at was the proportion of premature births. That, since 2006, has generally been on the decline, from 12% in 2006 to about between 9 and 10% in 2014. Still below anything we've seen in Ohio across the state. Infant born birth rate has also seen a decrease since 2011. It's fluctuated to some degree, but it's always been between 6 and 8% since 2006. And again, been on a general decline. Infant mortality rates have remained low. After I'm not sure, sometimes we deal with low numbers, sometimes even differentiation of 3 or 4 can be looked at as being significant. I'm not sure what happened in 2008 or 2007 when we didn't have any. But aside from that, infant mortality rates have generally been between 3 and 6 per year. Generally, usually lower than what we see across the state. We have seen a general decline in teenage births. Well, not so fast. Now, since 2001, we've seen a decline. Okay, that red line represents a trend line. But there's still been a lot of fluctuation. If you took 2001 and 2002 out of the equation, look at from 2003 on, that line would probably be a little bit flatter. So generally, I think the reason why we have a downward trend is because of the effects of those early years. But the good news is we're still, relatively speaking, at quite a low rate for a county this size. Now, another area that was of real interest, not only in this county, but also Wayne County, were the percentages of children who were uninsured for health. We are starting to see the effects of the Affordable Care Act and Medicaid expansion, but we're just starting to see the data from the effects of these two programs. The blue bar represents Ashland, and for our last 3 measurements, we were well above 17% of children being without health insurance. The last time I took a measurement from the American Community Survey, we were down below 12%. So that goes through 2013. So that's when we're starting to see some of that effect. But between these 2 time periods, that is a significant decrease. Still, if you compared Ashland, Wayne, and Holmes, that general area, and compare it to the rest of the state, our uninsured rate is much higher when you compare it to other counties. I think most people, when they hear that, they do have a suggestion that we have to get, this is not going to be why. Might be the effects of the Amish community, who statistically would not have health insurance that would qualify to be counted as being covered under health insurance. That could have an effect. Despite that, though, we're still seeing a dramatic reduction. And the children who are most likely to not have health insurance are children who are in a household that's under 1.3 of the poverty level, followed closely by those children who are in households up to about twice the poverty level. What's of interest here is, at least to me, is most of these children, and probably a good portion of these children, probably are in households that they are probably eligible to get their child on some type of health insurance. So that's health. Education, a couple of things to look at that. High school graduation rates are really high, much higher than we've seen in Ohio, always above about 92%. Ohio Achievement Assessment results, which is now undergoing a new way of measurement. But from what we had in Ashland, Ohio Achievement rates have been higher, proportionally higher than what we see across the state of Ohio. One data we're going to start to track is the third grade reading, which we had not done before. Third grade reading has been determined to be one of the best predictors of high school success in terms of how they score in reading in third grade. Risk behaviors. Number of adolescents being adjudicated for felonies, generally a downtrend, a decrease in that number. Now, I'm going to do my little paid advertisement here, unpaid advertisement actually. We don't have any current data for substance use. In Wayne County, we have a survey that measures youth assets and substance use in most of the school districts. And so that gets reported on every 2 years. What I would like to do, what I would like to see, is the school systems here in Ashland County to utilize this survey so that we can measure substance use and maybe more importantly, youth assets as a way, as a strategy to address the problem of risky behavior, specifically substance use. Child abuse and neglect. By the way, someone from an agency here? Great. This data was wonderful. This data was fantastic. I was able to do so much with it. So thank you. I don't know if it came to me directly, but it was a great data to work with. Because localized data is more powerful than it is if it's gone through reincarnations from various other people and then it finally gets to you. This is the total number of incidents investigated by maltreatment type. So these were reported incidents that were acted upon. A lot of fluctuation here. That's not surprising. Because oftentimes what determines what type of reports get seen and so forth, oftentimes has administrative capacity to it. But a great deal of fluctuation. But in 2014 we had 323 cases investigated, mostly due to neglect, but a good portion physical and sexual abuse. Not uncommon. In those areas, the most common maltreatment type of concern is neglect. In terms of substantiated report, in 2013, we did see an escalation in substantiated reports up to 127, probably because the number of incidents being looked at also increased. Now, the number of children in custody has actually decreased since 2012. And in the last 2 years, more children have left custody than entered into it. And 2/3 of children in custody have been in custody for less than 2 years. So, this graph, the line graph above, just shows the number of children who were in custody of the county on June 30th. So since 2012, a general decline. The graph above, the bar above, reflects those admitted and those terminated from custody during that particular 12-month cycle. So generally, through 2014, we have seen a general decrease in the number of children in custody. Probably as important, if not more important, is where did they go? When they left custody, what happened? In 2013, over 60% were reunified with their parents. As compared to what we saw in 2009, where the children leaving custody were primarily left custody because they went to a relative or kinship care, and not probably when they took over some type of guardianship of the children. Okay, so that was the secondary data that we utilized to help start establishing some type of story. Well, by the way, I know I'm going through this very quickly. I would like to post this PowerPoint on the website, if that's okay. For you. Look at this at your leisure. Most of this is in the report, but I think it's good to have a PowerPoint also to use it. Okay. So that's secondary data. Now we get into community health needs survey. And these are some general findings from the survey. We had general agreement that Ashland is a good place to raise children. Although, interesting, that agreement was strong from individuals who did not have children. General agreement that Ashland is a great place to grow old. But the biggest concern tended to be low wages, low income, and not surprisingly, the lower the income of the individual, the greater those concerns. And so this parallels very nicely with the secondary data that we have. Healthcare is available. That was a strong point in Ashland. Healthcare is available. However, there tends to be a long wait time for non-emergency care. Now, this is from the people who took the survey. There are concerns regarding quality and concerns regarding affordability. One of the biggest barriers that we see in terms of accessing health care is not having health insurance. It's having health insurance, but having a high deductible, having an insurance that doesn't cover particular procedures, and therefore, to some degree, it's almost not like having it. Ashland's a safe place to live. And also what came across constantly is that Ashland has a community spirit. You feel a part of the community. Although that tended to be more true for people who live in the city of Ashland than people who live outside of the city of Ashland. We track zip codes. There's a reason we track zip codes. So people who live in the rural areas of Ashland, the city of Ashland, they tended to sometimes feel as though not a part of the Ashland community because they don't live in the city now. But overall, they cite the community spirit. Areas of concern: drug abuse and low-income environment. Violence within family units. Interesting. There was a moderate concern regarding domestic violence and child abuse. There happened to be less concern with elder abuse. And that was kind of interesting. Don't have it up here, but those who were less concerned with elder abuse were the younger respondents. The older the respondent, the more concerned they were with elder abuse. But overall, there wasn't the concern with it. Low perception of problem levels, pollution, we have that as a concern. Lack of community support is not a concern. And discrimination, racism is not a concern. Behaviors with the most negative impact on the community. When people took the survey and were asked, which of these behaviors do you feel has the most negative impact for the community? Drug abuse, alcohol abuse, poor eating habits, lack of exercise, and obesity. Behaviors that we're seeing have least negative impact: racism, not using seatbelts, not being vaccinated. By the way, regarding racism, I don't have the demographics up here, but I think it is in the report though. 97% of the respondents are white Caucasians. And there's a truism is that oftentimes the group of people who are less likely to see racism are those who belong to the privileged group. That's just a fact. I would love to have seen more respondents from minority groups, but if you look at demographic data about Ashland as a community anyway, we have a low percentage of representation from minority groups regarding the racial. Also bullying was a concern. So services that need to be increased, higher paying employment, road maintenance. I just came in from 71 about TRD. You'd solve that problem. We have road maintenance, lots of it now. The availability of employment and positive team activities. Services that are simply need to be increased, we need affordable housing, services for people with disabilities, health family activities, and higher paying employment. And I put in parentheses, though, there was a great difference between lower and high income respondents. The lower the income of the respondents, the more likely they were to see that as being needed to be increased. The higher the income, the less likely they saw that these areas need to be increased. Parents who bring their children saw that recreation activities was needed and information was needed about recreation activities. Provision of social and emotional support. I'm going to come back to social and emotional support in a couple of minutes, because I have some striking information about that. And then dealing with difficult behaviors of children. This is things that parents want more information about. Okay, so for those parents who have children between the ages of birth and 5 years and or just pregnant, recreation activities was the one thing that they wanted more information about, followed by social and emotional support and dealing with the child behavior. Parents with older children, they saw that they wanted help in assisting their child and how to deal with peer pressure, dealing with bullying, good nutrition, how to address and handle drug abuse, and reckless driving, and reckless spending. I don't even remember I even had that on there, but okay, reckless spending. Or maybe it's E. I don't know. It might be a typo. But reckless driving, particularly that type of driving, one does when one is also texting. So by far, dealing with peer pressure was the number one concern. Now, in terms of the responder asked about being diagnosed by a healthcare professional during the last year, 4 out of, well, maybe it was not within the last year, but ever, but 4 out of 10 reported that they had been told by a professional in the healthcare industry that they had an overweight or obesity problem. 4 out of 10. Lower income levels more likely than higher income levels to have reported that. High blood pressure, over 3 out of 10. The older, the more likely. Not surprising. Depression and anxiety. Nearly 1 out of 3 reported having been told by a healthcare professional of depression and anxiety. That ratio surprises me. 1 out of 3. And females were more likely than males to be told that. Younger white people were more likely to be told that than older people. Now, when you control, I could have done a lot of this, but for the sake of what I'm doing right now, I'm going to leave it as brief as I can. Sometimes it's interesting to control for 2 demographic variables at the same time. So in this case, because of gender and age being a good predictor of feeling depressed or anxiety, have anxious behavior, as indicated by a professional, combine the 2 together. Females, in the survey, the females who answered the question and were under the age of 55, nearly 42% reported of being depressed or had anxiety, or at least the fact that the doctor told them that. 42%. Compare that to the male who's over 55, and it was like 10%. More about that a little bit later, because we have another question that further supports this finding. High cholesterol. Nearly 1 out of 3 reported having a high cholesterol level. Again, older, more likely than younger. So now we ask them the question, aside from the fact that maybe you haven't been diagnosed or been told, have you had a problem in daily functioning because of being sad, because of being worried? Has it affected your capacity to be able to carry out your various roles? Nearly 1 out of 5 stated that their daily functioning had been compromised due to being sad or worried in the last 30 days. Younger respondents and lower income individuals were more likely to have this experience. Again, we're going to find out that poverty is a great stress producer. 1 out of 6 stated that in the last 30 days their functioning had been compromised due to being anxious, confused, or overwhelmed. Again, females, younger respondents, lower income individuals were more likely to report this. And 1 out of 4 experienced physical pain or health problems that kept them from carrying out their activities. Lower income individuals were more likely to have had this than higher income ones. And this is kind of, this shows this in a graph form. So in terms of normal visit due to being worried or anxious, nearly 20% said yes, but 21.6% of females, 27.1% those under age 55, and 28.8% with incomes of less than 55,000 reported that to be true. Compare that to the antithesis of that group. And then in terms of being overwhelmed, being able to go about your own business, you see the same type of scenario playing out. This is physical pain. Again, we don't see that much difference with age and gender in terms of physical pain, but we do with income. With lower income levels, people are more likely to report physical pain keeping them from their goals. Some other things, 70% stated that they did engage in some form of physical activity once a week. Those who indicated not engaging said that it was due to lack of time, being too tired, not liking to exercise, or not having anyone to exercise with. And then, of course, I had to say, I wonder how this is connected with being sad or worried, right? Well, those that indicated not engaging in some form of physical activities were over twice as likely to report being sad or worried than affected their daily functioning. But yes, exercise is good for you in more ways than one. It's great for mental health. Smoking. Under 11% of respondents indicate use tobacco of any form. Now, we don't have any trend data for this type of survey, but generally I think the trend is to go down dramatically. Access to health care. 1 out of 5 indicated having problems obtaining health care for themselves or a family member during the past year. And the reasons for the barriers were listed in the order that was cited. Insurance coverage, too long a wait, not being able to get an appointment, lack of transportation, and then not just knowing where even to go. So that's a community survey. One other thing I want to add to this before I get into the focus groups is that, and I did this later on, because I was kind of implicit. We asked respondents what they would like to see more of. What do they need more in their personal life to assist them and be able to carry out their roles. And those who indicated feeling depressed, worried, anxious, and so forth, they, by and large, were not requesting more mental health services. They were not requesting more professionals to go to. What they were requesting was to meet with people like themselves who are undergoing the same type of concern, situation, problems, and so forth, so they can share with one another. And just the sharing itself can be helpful, but also then to share ideas with one another. In other words, they want to meet with more people like themselves going through the same experiences, because many of them felt isolated, that they're in it all alone. And if you could just have some support mechanisms, that would be extremely helpful. Also, you know what, it's less stigmatizing. When you go to someone who is like yourself and so forth, and you're sharing together, yeah, I have that same problem, yeah. Whereas if you're looking at going to a professional, nothing wrong with doing that at all. But that stigma is, oh, there's something pathologically wrong with me. And that itself is a big barrier to go through before you can see it. Focus groups. We had a series of 6 focus groups. As indicated, 3 were conducted by the Mental Health Recovery Board and the other 3 Ashland Health Departments. And the participants tended to come from a similar walk of life. So we had one that were veterans, another group of ministers, senior citizens, schools and business, access board members, and strengthened members, and support group strengthened members. This overall, here are some general things that came out. Again, you will see some of this being replicative of results that we saw both in the secondary data and community survey. That there is cohesiveness and togetherness that describes this community. There are lots of caring people who volunteer their time, effort, and money to be a place to raise kids. Generally a safe place to live, a good place to retire, a solid faith-based foundation. University presence is felt as to the appeal of the economy to the community. And there was much pride. Many people talk about the proximity. There was much pride in the proximity and what it brings to the community. Concerns? Well, we've seen this again. Low wages. And also concern is individuals must often compromise the best interests of the family for their job. They're being asked to sacrifice togetherness with family in order to be able to meet the needs of their employer. As simple as needing time off from work to attend to a sick child. One of the barriers I found in some of these is in terms of getting your child to the dentist often requires having to take time off from work to get your child to the dentist because there wasn't much availability in terms of dentists who were accessible during evening hours or on the weekend. They're concerned about that they had a high level of compliments regarding doctors, per se, but they also felt that because of the number of those retiring, that the number of doctors who get their practice started here in the county, they leave. They had lack of access to specialists, that they have to go out of the area to reach specialists in many times. And sometimes, many of them commented about having to utilize the ER, not because that was their first choice, but it was because they could not get into a conflict position. Other concerns was a lack of coordination between social service agencies, an increased need for food assistance, which, as you could tell by other data, support that. There has been increasing with food assistance. But that's resulted in longer wait times in food banks. Drug abuse, affordable housing, insufficient shelter beds. Transportation unavailable for many and not at the right time, and particularly if you get outside of this metropolitan city area. The education system was seen as being financially stressed, always worried about where the next dollars would be coming from. Now, here's one observation. There are too many children in custody, resulting in budgetary problems at the county level. Now, I'm not sure what the budget is at the county level, but again, this was an impression that there are too many children in custody, but again, our data shows that it actually has gone down to some degree. A decreasing proportion of intact families, being defined as having two parents in it, and an over-reliance by many on public assistance. Now, again, if you look at public assistance overall, we do have a lot of people on public assistance if you look at all types of public assistance. But usually when people talk about public assistance, they tend to talk about the cash public assistance. Okay? And it always is the impression, maybe it's the media that drives this or whoever, I don't know. But we get the impression is, my God, there's hundreds of thousands of people out there milking the system for all it's worth. And yet, if you look at the data in terms of those number of families receiving Buchanan, I got that data from the Ohio Jobs and Family Services. I was absolutely floored by how low that number is. And then their average benefit level was around $400 a month. Oh, that's it. Okay. So those are the three areas. We're going to take questions now. Okay. Have a few more minutes to go ahead and address any questions you might have. Again, I think good data produces more questions. So I may not have the answer, but at least I can just explore some possibilities.
I guess my first question would be on the unemployment rolls.
Yes.
How do you take the difference between the unemployment rolls and those that are actually fallen off of the unemployment rolls and are no longer, have just given up?
Good question. Because that was the official poverty rate.
Okay.
That was the official poverty rate. And there are, if you ever go to the Department of Labor Statistics, because they address some of those concerns in terms of, well, who do you factor into unemployment? Who do you factor out? There are actually 6 ways of measuring unemployment now, only one of which is the official unemployment rate. But there are actually 6. So if you go on the Labor Statistics website, you will see U1, U2, U3, all the way through U6. Okay? And so you can get information at least on a national level and probably a state level, but we don't have that at the local level, unfortunately, regarding those various ways of measuring unemployment. However, at the national level, and probably at the state level too, no matter how you're measuring unemployment, the numbers, of course, change because you're including or excluding more people, but the trend looks the same. So there's an incredible correlation between all 6 of those ways of measuring. So I can say with pretty much confidence, unemployment has gone down significantly since 2009. And so either, whether or not to include them or not, the same trend would be seen, but the numbers, of course, would be different.
You mentioned the website several times. I don't see it listed on this program. What website is it?
Yeah, what website are you referring to?
Yes, it's www.ashlandmhrb.org. That's the main one. There's a /FCFC for Family Children First. All of this information then will, if you send me a PowerPoint, will come out also. So this document that you have here.
So Ashland for the Home Recovery Board's website.
Right. Yeah.
Is this on electronic building or what?
Is that on? Yep.
Yes.
Okay.
Any other questions? In your correlation from the study, have you found the difference between higher income, medium income, and low income when it comes to the big four? That is, emotional, sexual,
In terms of, when you say those four categories that's representing what?
emotional,
Yeah.
sexual, and physical, and neglect.
Well, in terms of the child,
Child, yes.
okay. And the question is, how is that related to what?
The variation in terms of economic opportunity, that is, higher income, medium income, and low income.
Excellent question. We would have to have had demographic information about those various children and their family of origin and so forth. We do not have that data to be able to do that. Excellent question, though, because that would be greatly of interest in terms of how this is associated with child abuse and neglect.
It is, yeah. And I really appreciate your excellent presentation. You kind of got up a lot of points that I want to look at the broad picture as well as the specific need or immediate response. Thank you so much.
Any other questions? Okay, thank you.
What I'd like to address now is the next steps to the process. This was a lot to absorb for the planning committee, as I'm sure it is for you. I appreciate Dr. Vermont and all his expertise and work. So I'll just go over now the prioritization process. The planning committee met and over a couple of meetings just try to digest this and try to decide what's next. What are the top, first of all, strengths of Ashland? Because we don't want to just dive into, okay, what are the things that are needing addressed, the issues. We want to celebrate the strengths too. And Dr. Beaumont covered some of these. So we narrowed it down to 4, and we said that the community supports and the resources, and many of you in the rooms represent those organizations. That we have good birth outcomes, and that the education, there's high graduation rates and good schools. And that this community is safe and there's a low crime rate. And the other one that I would add to it, because it did come out loud and strong, was the solid faith-based community that we have and what they bring to the community. So then the areas of concerns. Health, we decided encompassed a lot. And as you can see, emotional and physical we were looking at. Overweight, obesity, depression, anxiety, and again, we took it from the data, but we had to try to narrow it down, and it was very difficult. The lack of physical activity or healthy eating, female mental health, availability of primary care physicians and specialists in the county, and availability of home-based services, and availability of special needs services. So all of that under emotional and physical health. The next one, family violence and child abuse and neglect. And then another, drug abuse, addictions, and the opiate overuse or abuse. And then poverty, and underneath that, the lack of employment, lack of livable wage, and food insecurity. So we, as a committee, looked at all of these and thought, okay, how many of these should Ashland County really try to attack and address? And it chose all 4. So we know it's going to require a county-wide effort to do that. But we also all agree that sitting and doing nothing and then just saying these are problems is not going to get us anywhere. We really need to at least try something in each of the areas to make this better. And so to address the top areas of concerns, we are forming what we're calling target action groups. Okay. And the members of the Family and Children First Planning Committee volunteered to chair and co-chair these committees, and which are the target action groups. And those are, and I color-coded them very specifically because we have sign-up sheets later on that you can sign up. And the sign-up sheets are the same color of these. That's just a little, try to make it as easy as possible. The health and wellness will be co-chaired by Dwayne Dre from the Health Department and Jill Hartson from the Samaritan Health. And then preventing and overcoming addiction, David Ross will be chairing, and along with the Opiate Coalition will help with that. And then eliminating interpersonal violence and child abuse. And interpersonal violence can be any type of abuse or violence happening within intimate relationships or family violence. And then that one is going to be co-chaired by Cassandra Holtzman from JFS and Catherine Swope from Parenting Plus. And then building bridges out of poverty, Freddie Robles from Catholic Charities will be chairing that one. So I'm very thankful that we've had people who are willing to step up and lead these charges. They won't be left to try to figure out what to do from here, because we do have a structure of what we're going to charge, the task, a logic model that each group will be following, and we'll be having a meeting to get together with all of them. So the next steps are the target action groups. They're designed to bring the service agencies together with the businesses, faith-based organizations, and the community members, whoever would like to come and partner. And it was asked of me, why should we do all this? And I said, if 16 organizations just stay within their walls and just do what they normally do based on the limited funding that they have, we will not be able to affect these as much as if we all come together and bring whatever resources we have and knowledge and expertise, because there's a lot in this room and there's a lot in this county. And there's retired people in the community with expertise, there's family members and moms and dads, and if we can get whatever your passion is to bring to the table to help with this, we welcome all. And then the target action groups, like I said, will follow a logic model, the guide their steps, and establish and implement an action plan. And then they will review their progress and report to the planning committee, at least quarterly, and then we will also look at the program as a whole. For an example, in Wayne County, we have been doing this process for a while, and we realized that these take time. It's not like in 3 months we're just going to have made a huge dent and this will it takes a year, 2 years, but we're going to start making steps towards attacking these areas. And these are some of the questions that, it's not an easy process for people to get into the room. Well, you saw all the things that health and the physical and emotional health people said that they wanted to look at. So you think, where do you even begin? So first we start to look at the information that we have, the data we already collected. Do we need more local data? Sometimes questions in the room are like, is this really true? Is this really what's happening? And so, like in Wayne County, they did another got some more local data in a certain area. So we might do that too. And then who is already working on the area of concerns, what programs already exist. We certainly are not trying to do this to duplicate any services. If there's somebody who's working on the area, we want them to join us in this. So, and we're not trying to exclude anyone. So if the group gets together and they go, wait a second, so-and-so should have been here because they're also working on this, that's what we need to know. Who else should be brought to the table? And then what can we impact? Because we obviously want to have the goal be achievable. Whatever we're going to be working on, we want to start to maybe it's a small change, and then add to that, and then add to that. And decide, maybe there's a target population. Poverty is a huge thing. So, like, where do you begin is usually the first question. And so looking at the data and maybe, like we were looking at the single parent households, a female single parent household, almost 50% of them are in poverty. And then we're looking at the fact that they're experiencing anxiety, depression, stress. So maybe that's a target. I'm just throwing out there. I don't know, that's what the group will decide. But you can see how we have to narrow it down to start somewhere. And then what are the resources already available? What are resources we could go after? How can we pool each a little bit? I can tell you just an example from getting the documents printed today, just how everybody worked on it and provided a little piece. It's just amazing, just from a little bit like that, how it got done. So, and what are the barriers? And certainly, we could all sit in the room and just complain about the way things are and all the barriers and everything, but that's not going to make progress. So, going back to it, we would have sign-up sheets so that you can attend an action group and see if it's something that you're interested in. We're not saying that there's a time commitment and length of involvement. If you want to show up at one meeting, share some ideas, share some resources, your expertise, or then decide if you want to serve on one of these. That would be helpful. Anything we would welcome. And the sign-up sheets are available here today. And also, you can email me, and I will make sure that your information gets out to the right chair or co-chair of the target action groups. And again, here they are. And I also wanted to just share that how important this is. Sometimes when we're hearing about this and looking at the data, and we're just thinking like, I don't know. For me personally, this has meaning. Because I looked at this and I saw my own life. And I thought, wow, I've experienced a lot of these things. And if it weren't for people who came up to me and said, I care, and I will mentor you, and I will help you, and I will show you a better way, I would not be standing here before you today. And we all are a work in progress, and we need each other, and we need help. And so you might not think that your gift or talent or your expertise has meaning, but I can tell you that if there's power in just knowing that one person cares about you in this life. And so if you just have a heart for caring about people and want to come to one of these target action groups, we welcome that. So thank you for coming today and for your time. And we will have this on the Ashland County Mental Health and Recovery Board website with all the PowerPoints. And also, Ray from the Health Department has made this into, or will be making this into a YouTube video. And so thank you. I appreciate it.